A very good evening and a warm welcome to one and all present here. I am Debolina from Clearnet, and I would like to thank everyone who have joined in this session. Clearnet is very proud to be a part of this webinar as a digital partner. So with all of you, now I am going to play a short video of Clearnet. Thank you so much everyone for your patience. Our website is www.clearnet.com. There we have lots of live sessions conducted by eminent speakers across the globe. Besides, we have MedWiki services, which is medical Wikipedia for doctors only. That also you can read in your leisure time. So now, without further ado, I would like to hand over the session to Dr. Aarti Kinikar ma'am to start with our today's session. Over to you.
Thank you, Debelina. Good evening, everyone, and welcome to the IAP PG Clinic, which is actually a second season, you can call it. First, Dr. Prajapati sir and Dr. Yogesh Parekh sir have started it, and I think it has become very popular all over the country, with many experts helping our PG students to do their best and learn the basics and the art of history taking examination, and also preparing all of you to do your best at the practical exams. And it will always help you in your practice in future as well. So special thanks to Dr. Yogesh Parekh sir, who is presently the Vice President of Central IAP West Zone. And I think so he is one of those active persons who make sure that we all are on our toes, and we do this sessions regularly on Saturdays. And without Dr. Prajapati sir over there, I don't think so we would have reached this stage of the second session.
No, madam. No.
Thank you so much, sir, for all your inputs, and you are the guiding pillar over here for these sessions. And today we are going for a neurology case, which will be presented by Dr. Prachi Vani. And Prachi, you are a third year student from Mukh Swami Medical College, right? Karamsad,
Yes.
Gujarat. Yeah. So welcome, and don't be bogged down by all the senior faculty who is here. We are all learning, as Dr. Prajapati sir, every time he says, we are all learning from each other and from the students as well. And Dr. Jigar is the guiding force behind this presentation and who has mentored you during these sessions. And he is also attached as HOD Pramukh Swami Medical College, Karamsad. And today we have two experts who are here. Dr. Kalpana Datta, madam. Welcome, madam. And madam needs no introduction, but for the young people who are here, I will very quickly tell you how talented she is and multitasking. I call her every time I see her, she's fresh and multitasking. Madam is presently the professor of pediatrics and director of the Pediatric Center of Excellence in HIV care in Medical College, Kolkata. And she is one of the pioneers of HIV care of children in West Bengal. She is President-elect 2022 of West Bengal Academy of Pediatrics, also President, Association of Pediatric Neurology, Bengal, from 2015 to 22. It's a long time she's held that position. And she's very closely associated with the neurology chapter of IAP as well as the West Bengal IAP chapters, and held many positions like EP member at various platforms in the IAP. She has been a master trainer for almost all the Government of India programs and has been training, teaching, guiding a number of students and faculty over there, as well as she is on various expert committees since 2017 to 22, CDSCO, etc. Has published over 55 papers in various journals, which are very useful for our practice, and reviewer on many international journals, and of course, life member of almost all the chapters of IAP. So welcome, madam. And I'm sure because of your neurology background, which is there, and also infectious disease, etc., Dr. Prachi, you are in most comfortable hands of learning from madam. And next, our expert is Dr. Rajesh Kulkarni. He has been working with us in the past at BJ Government Medical College in Pune, but now has shifted over as Associate Professor of Pediatrics at Postgraduate Institute, YCM Pune. He has got an experience of over 18 years as undergraduate and postgraduate teacher and has been an examiner for a UG, PG as well. And for 21-22, he has been a Pune IIP PG clinic convener. So he has been very actively mentoring the PG students here in Pune and Maharashtra. He is also one of the Fogarty scholars from National Institute of Health US through the Johns Hopkins University and involved in research with HIV, TB and other infectious disease. Yeah, he is very fond of publishing articles. Okay, so he works very hard, very systematic, and makes sure that we all are with him so that we get very good quality research publications out in both indexed and international and national journals. His interest is neurology and pediatric ICU, and he is a BLS trainer as well. So I'm sure with both the experts and of course with Dr. Prajapati sir, this session on CNS case is going to be really very good. I can see on screen Dr. Chinmay also. Welcome, Dr. Chinmay. And Dr. Jigar has worked hard with Dr. Prachi. So welcome, sir. And I'm sure she's going to do very well in this session. And it's basically to learn how to approach a case. The diagnosis is not important, but how did you arrive to that and the justifications for that is what we are going to see. So I will hand over to Dr. Prajapati sir because he usually starts off the session and then Dr. Prachi will go ahead with the presentation. Over to you, sir.
Good evening, friends. Thank you very much, madam, for your kind words. And I think so many adjectives, we are not sure whether we are deserving or not. But certainly, I think it's encouraging that we should try to deserve all these adjectives. Thank you very much, madam. I think my request to Prachi and Chinmay, all your other friends and colleagues, I think they should be on the panelist link. They must be probably in the attendees link. Even I may request Dr. Jigar because we know that the students must be under the control of the teacher and it makes difference. The reason is, if more students, more discussing, more interacting, and silently just listening probably make difference, but not that much. If we actively discuss, that definitely it makes difference. As madam said, particularly in the performance in your exams, because this gives us the training. So I think you may try to call our other friends and they should join this panelist link. As madam said, Dr. Prachi, she is the student from Pramukh Swami Medical College and she is a presenter, and as naturally Dr. Jigar must have taken the lots of the pain for mentoring her. And I'm sure that with this session we'll utilize the 2 hours for best of our learning with the help of even the experts in the neurology, Dr. Kalpana and Dr. Rajesh. I'm sure that naturally when as a general pediatrician, we are knowing probably when we end, they will start beyond that. And ultimately, in short, we will learn a lot in this neurology. With this remark, I request Dr. Prachi to share her PPT and start the history part. Dr. Prachi, please.
Yes, sir. First of all, good evening, sir. And thank you for giving this opportunity. Today I'm, sir, is PPT is there?
Yes, can you make it full screen? Prachi?
Yes, sir. Yes, sir.
Yes, now it is safe and you are audible. Please go ahead.
Okay. I am presenting a case of 10 year 7-month-old male patient who is 7th born out of the non-consensual marriage named XYZ, residing at Pandoli, Gujarat, and Hindu by religion, belonging to lower socio-economic class according to Modern Economy Scale 2021. Informant is father and is reliable. Date of admission is 14th December 2022 and date of examination is 18th December 2022. Patient presented with chief complaint of fever for 15 days. Sir, am I audible?
Yes, yes,
Yes,
you are
yes.
audible. Please go ahead.
Yes, yes.
Okay.
I think I understand. I don't know, but some background noise must be interfering you, but you are audible.
Okay, thank you, sir. Patient presented with chief complaints of fever for 15 days, episode of abnormal movement before 15 days, loss of appetite for 15 days, vomiting for 3 days, and altered sensorium for 3 days.
Yes, Prachi, you can take it further for details.
Okay, yes. On the elaborating my chief complaints, patient was apparently well before 15 days and then presented with complaint of fever for last 15 days, which was moderate grade, intermittent, undocumented, associated with generalized weakness and not associated with chills or rigor. Fever was temporarily relieved on taking medication and require medication 2 to 3 times a day. Fever was subsided after 5 days and then again reappeared after 3 days, which was low grade, evening rise mainly, associated with generalized weakness, decreased activity, and fever was relieved on taking medication. Complaint of one episode of abnormal movement in form of tonic posturing of all four limb lasted for 3 days, which was associated with uprolling of eyeball, frothing from mouth, passage of urine, and resolved spontaneously and followed by postictal phase of 10 to 15 minutes. History of reduced oral intakes in 15 days associated with weight loss in form of loosening of clothes. Vomiting for last 3 days containing food particle, non-bilious, non-blood containing, and projectile in nature. Altered sensorium for 3 days in form of excessive sleepiness, unable to do routine activities by himself, and unable to carry out proper conversation with family members. There was no history of double vision, behavioral abnormality, limb weakness, abdominal pain, loose stool, reduced urine output, skin lesion, rash, ear discharge, cough, and breathlessness. On proceeding to treatment history with complaint of fever and abnormal movement, patient was taken to private hospital before the first appearance of symptom, that is fever and abnormal movement, where blood investigations were suggestive of dengue fever, and he was managed with IV fluid and IV antibiotics and medications and discharged after 5 days of the hospital course.
Okay, I think can you stop sharing now? Because you have provided a lot many informations.
Yes, sir.
Prachi, you may stop sharing your presentation for a while.
Yes.
Sir, I think,
Okay.
I think she's trying.
but
Yes.
I think it should stay so that we can have our comments on it.
You can go to the first slide, Dr. Prachi.
Yes, ekdam very first slide.
Chief complaints.
I make it a slideshow. Is it a slideshow? Vijay?
This is good. Yeah, this is good.
Okay.
The slide is visible.
Yes.
Yes, yes, it is seen. It is seen.
Okay.
Madam, would you like to take it further?
Yes, sir. Can I comment, sir? Yeah.
Yes, 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 yes. Please.
First of all, good evening to everyone. And thanks, Aarti, for your exuberant introduction and kind words about me. And I'm really happy to be and honored to be here as an expert. And I'll take it. I think Prachi, I don't keep so much in the chief complaints. Say there is 5 complaints. You can
Yes.
keep 2 or 3. One thing you say, just see your chief complaint.
Madam, I think it requires adjustment of your mic or so.
Yes, yes. Oh, adjustment in mic.
Yeah, Now it is good.
Okay. So fever for 15 days, and you see next is episode of abnormal. I'm getting background noise. I don't know. Some voice is coming.
Yeah.
Episode of abnormal movement before 15 days. So that is not clear. You said a fever for 15 days, chief complaint. If it is a chronological order, then I don't understand what did you mean by before 15 days. First thing, is it the within the febrile episode of the seizure or one episode of abnormal movement before 15 days have written, loss of appetite 15 days, vomiting 3 days, altered sensation 3 days. So he could have written only fever for 15 days and altered sensation for 3 days. Then in history of presentation, he could have elaborated. So what do you mean by abnormal movement before 15 days?
Ma'am, patient.
Not according to the chronological order, you know. So why before 15 days means? I could not get it.
Patient
Yeah,
had
Dr.
one episode
Prachi.
of abnormal movement. Abnormal movement episode was noted only once before the 15 days. Matlab, with the fever, patient had abnormal movements.
Yes, with the fever. Now what? So we just write the fever 15 days and altered sensation for 3 days. This is sufficient to suffice that this is the case of neurological disorder. This altered sensorium. Any disturbances? Anything?
No, it's all right.
We
Okay,
can
I
hear
don't-
you, ma'am.
Yeah, I am
can
getting
go.
some disturbances. Okay, so I think it will be better if you keep a fever for 15 days. And of course, loss of appetite, vomiting is, you can explain in history of present. Most important chief complaints is the chief. You see, it is a chief complaint. So you mean to say the fever and altered sensorium. That is suffice. 15 days and 3 days. Now come to the second slide again. You see, there is no continuity in the history. You written to a patient within the 15 days, which moderate grade. Okay, you have explained about the fever, but again, while discussing the fever, what is the aim of us? You have to check out what is the cause of fever. You know, fever means release of pyrogens, maybe endogenous, maybe exogenous. The commonest is the exogenous. That is because of the infection. So, what is the site of infection? Our motto is to establish the cause of fever and, of course, the subsequent events. So, when you have written associated with generalized weakness, not associated with chills and rigor, that means you wanted to rule out something, chills and rigor, like malaria, UTI, whatever, whatnot, cholangitis and all, and temporarily relieved on taking medication, but it didn't ask about the any cough and cold or any UTI features of other infections or other side, so that it can localize the infection. Okay, got my point? You have not elaborated the fever, whether fever is related to upper respiratory tract, lower respiratory tract, GI infection, or anything. After, again, you have completed this history and you said one episode of abnormal movement in the form of tonic posturing, all 4 limbs, lasted for 3 minutes. At what time? After the how many days of fever? This is also not clear. I think, where is the slide presentation gone? I'm not getting the slide presentation.
Prachi, can you just share the slide for Madam, please? And I'll request all the others if they can mute their mics so that the disturbance can be reduced. Yeah. Yes, Prachi. Yeah.
Slideshow mode. Slideshow. Make it slideshow. So you see, you have written the abnormal movements in the form of tonic posturing for all 4 limbs lasted for 3 minutes, which was associated with the uprolling eyeballs. Okay, you have described this, but at what time of the which day of fever? At the beginning, you have written the more than 15 days, above before 15 days. Here, you have not mentioned the duration and timing. Okay. Again, slide is gone.
Okay, Dr. Prachi, I agree with Madam. Thank you, Kinika ma'am, for giving me this opportunity to be here, and it is really wonderful to be here. And what ma'am said, I totally agree with her. That your history has to be very coherent. It should be like a story where I
Yes.
understand which event has happened when. So suppose what I understand now is that the fever and seizure probably happened on the same day. And suppose it was that the seizure happened on day 15 of fever. Your differential diagnosis are totally different, isn't it? So, you need to be very clear in your history as to when fever started, when was the seizure, and you have explained that the child's sensorium was poor and there was vomiting and there was altered sensorium. All that is there. So instead of 5 complaints, I would say fever
Yes.
and you
Altered
could say, if
sensorium.
you want to say, you could say paroxysmal event. If you don't want to say seizure directly, you could say that it was instead of involuntary, instead of a movement, abnormal movement. I would probably use the word, a paroxysmal event. That would be a better word to use. So you say fever and a paroxysmal event 15 days before, and vomiting and disturbed cognition, or you could say sleepiness 3 days before the child was brought to you. That would reduce the number of chief complaints, and that would convey correctly what you were trying to say.
Yes, yes, I could totally agree with you, Dr. Rajesh. And then the sequence of events, even it's not clear. Sequence of events and what happened after the convulsion, and you have written, if you go through the next slides, you have gone through some hospital, admitted for 5 days. So there's no continuity. You just tell me what happened for the last 15 days. Story about the last 15 days. Dr. Prachi, please tell me the story of the last 15. What happened? The baby had a fever, convulsion or abnormal movement. Then what happened? Then what happened for 12 days? Then after 3 days prior to the presenting to you, baby had a vomiting and whatnot.
Yes,
3
ma'am.
days. Yeah. So just tell me the continuity. What happened in the last 15 days?
Ma'am, first patient had developed fever, and on the same day evening, patient had one episode of abnormal movement, which was subsided by its own. But after that, patient was taken to a private hospital where he was admitted, and at that hospital, patient was giving some IV fluids and injectable medications. After 5 days, patient was discharged from that hospital, and patient was afebrile for 2 to 3 days then after.
Okay, good.
And then again fever was reappeared, and followed by there was episode of vomiting, altered sensorium, and then patient was presented to our hospital.
So
Okay,
Dr.
now it's
Prachi, if you were the treating, say, pediatrician on the day of seizure, this is a 10-year-old child who came to you with acute fever, short duration fever and seizure on the same day. What would you think of?
Sir, as patient is having fever and with altered with seizure, so firstly there is encephalitis changes are present there. Patient
Okay, one possibility. Okay, one possibility is you are saying this is encephalitis.
yes.
Okay.
And sir, it is acute, so it can be viral, can be
Right.
bacterial, but more it can be viral.
Okay.
Sir, the age of patient is 10 years, so there is low possibility of febrile convulsion at this age group.
Okay, so we will not call it febrile convulsion, isn't it? At 10 years, you don't want to call it a febrile convulsion.
Then it could be a fever-induced seizure. When you talk to febrile convulsions, and it could be a fever-induced seizure. Might be suffering from seizure in the past, and it is induced by again fever. That could be the one possibility, but that will be ruled out by taking the past history. Okay, keep it aside. Okay, continue.
There can be
hypoglycemia.
Any metabolic changes due to fever, so can be hypoglycemia induced seizure, or less likely hypocalcemia induced seizure can also present.
Okay, how common would be hypoglycemia in a 10-year-old?
Less common,
just one spike of fever and then a hypoglycemia, then a seizure is little unusual in a 10-year-old. If it was a 1-year-old, you would think of it, isn't it? Because
yes,
metabolic issues would manifest early.
Yeah, in some rare situation like in Jamshid, Muzaffarpur lychee incident and all, that's a entirely different thing. So you don't think in all the cases.
And for encephalitis, what is not there? So this child was okay, then had a fever single day, had seizure, one single seizure, GTCS type, correct? So what more is usually there in encephalitis? We say it is encephalitis, not meningitis, isn't it?
Yes.
Altered sensorium.
Yes.
Very good. Okay. So generally, acute viral encephalitis would have a history of fever for say 2-3 days. Third day, the child is in altered sensorium and has seizures. and generally a focal seizure, isn't it? If you take classically herpes simplex, then classically a focal seizure, maybe generalized, but classically you want a focal seizure, isn't it?
Yes, sir.
Right. Okay. Any other possibilities you thought of?
Sir, can be
Any inflammatory conditions? Okay, any other, yeah. Prachi, any other students can answer also, if there's other students.
pyogenic meningitis, pyogenic meningoencephalitis,
Okay,
or brain abscess.
yes. Could it be tuberculoma or NCC?
Yes, sir.
Have you seen a patient?
Yeah,
representing this?
NCC is less likely because there is presence of fever, but tuberculoma can be present. But for that, history of 1 day of fever is
Very
not
unlikely.
surprise. Yes.
Anything other than this? Would you call it as there's no abnormal, there's no changes in the consciousness, no, sir? Only convulsion and fever.
Yes, ma'am.
Altered sensation is not there at that time.
So
So
at
it's
that
not
time,
encephalitis.
what
So it is not
Madam said,
encephalitis.
yeah, that it could just be a very high fever, 105, 106. An older child may throw a seizure. Okay, single seizure and then be okay. Now at that time, you don't know that this child is going to have vomiting, altered sensorium, and
Yes.
problems later on. Okay, so at that time, when you first saw the child, there's one point I would like to tell you that in acute pyogenic meningitis, seizure is a late presentation. Okay, so they will classically come with fever, headache, and altered sensoria. Okay, and seizure is usually a late presentation. That is first. In tuberculoma and NCC, there may be or may not be fever because remember
Yes.
it is an immune-mediated reaction. So they generally will come with a focal seizure to you. And therefore, when a focal seizure comes to you, the first thing you do is a neuroimaging because you don't want to do a lumbar puncture there because you know that there could be raised ICP and whatnot. Okay, so generalized seizure, your diagnosis of tuberculoma and NCC, less likely, it is not impossible, but you would think of it more commonly in a focal seizure instead of a generalized seizure.
Generalized.
Yeah, so go ahead now. Now we want to hear the rest of the story. We understood that there was fever and a single paroxysmal event in the form of a seizure, GTCS. So then
Yes.
what happened?
I think Prachi, just can you stop sharing for a while?
Yes, ma'am.
Yes, sir.
I hope you know how to stop sharing the red button.
Sir, I have stopped sharing.
Okay,
Is-
now, yes.
Okay.
I think very interesting story what our experts friends have derived. What is the exact duration of the illness? Is it 15 days or beyond that? What is your thoughts?
Sir, present in complaint is of 15 days, but there can
I think
be.
let me talk to Chinmay. Chinmay is also attending the story. Chinmay, because Prachi may be biased, whatever she has thought of. Probably we are unbiased. We don't know the story. So Chinmay, can you think independently the way in which Prachi has described the story of illness of total 15 days? Do you agree is of 15 days illness only or beyond that?
Sir, according to me, what I have been thinking is this whatever pathology is causing this, it
No, Chinmay, in the exam, I give the idea, always address the question. Right, don't deviate from that. As some political parties are discussing on the television, we will not go like that. We will answer the targeted question. And that is also very important. Suppose if you don't know, say that don't know. Here my point is, you agree that it's a duration of illness of only 15 days, what's it describing, or something else? What is your idea?
sir, it is likely to be more than 15 days because
Why? Yes, why then? What is your explanation?
initially the presenting complaint, Prachi has mentioned that 15 days ago the patient has the episode which somewhat looks like the convulsion seizure episode.
I think that she made the point clear. That was on the day of fever only. So it comes in the 15 days.
Sir, it must have included a prodrome, something of some symptoms which might have been missed by the parents, and finally they have not had,
Why you are thinking like that? Why you are thinking?
sir. I think sir,
Because father said 15 days. But if you are thinking that maybe even beyond that, why you are thinking like that? What is your idea? Each point makes you to think that probably it may be more than 15 days. You should have some reasoning. You should have some idea.
during system pathology, looking simply at the chief complaints of vomiting, altered sensorium, fever, and it appears to me, sir, that the patient might we might also consider something such as a GI pathology.
Is it GI pathology?
In acute, so patient may be sort of acute liver failure, maybe presenting as hepatic encephalopathy.
Do you have these, I will say, thoughts in this patient? Why are thinking for hepatic encephalopathy? Anyway, what was my point?
Simply,
what I wanted to convey, let me make the point clear. In such patients, it is very subtle, parents will complain when the symptoms are there. High-grade fever is a problem. Seizures is a problem. But at the same time, there is Prachi mentioned the significant weight loss. Weight loss is not expected in 15 days' time. And therefore, it is likely that these some symptoms, and therefore what she used the word, apparently normal. So what was not apparently? Parents will complain of only prominent problems, symptoms. Some other things, they may not give the importance. But once I realized that probably the 15 days time for the story started, before that child may have some problems. And for that reason, if you ask whether I think 10 years old child must be going to the school. If you ask whether the child was going on the school previously of even the illness, 15-day fever, whether the child was having the same activity, child was suppose 10 years old child must be playing with others, whether the activity of playing, whether the appetite, all the problems, what I mean to say, likely that maybe even before the 15 days, which parents may not give the importance or may not realize unless we ask them. If we ask them, then they will probably admit everything that yes, this was that. So I think in this type of the story or chronic illness or this type of illness, once you feel that probably problem might have started before this onset of all the symptoms, you should act retrospectively. And even you can narrate your story in this way, that following this, all the issues of 15 days, I thought that apparently what they say normal, but maybe probably some hidden problems or complaints, which probably parents have not admitted and are asking them, probing. They mention all the things which you can come out, I think maybe there. The decreased appetite, decreased activity, may not be well, probably maybe there is some absenteeism in the school. So all these problems might be there. And of course, later on, started this fever and the whole story. So I think that part should not be missed for the postgraduate. Undergraduate, it's all right. But this is expected in the postgraduate, that some hepatic problem, this type of CNS problem, or some metabolic disorders, before the acute onset of the illness, they have some prodromal or they have some hidden complaints, which probably it gives the importance to us to understand the disease. Right. So I think that was the point of which you should take it. Rest of the things very
Yeah, I want
right.
to add.
Yes, yes, madam, please.
Yes, yeah. 1 day fever in 10 years old with convulsion, though it's very unlikely, but meningitis, pyogenic meningitis, as my other expert said,
Yeah, yeah.
can have a fever in the convulsion the very first day because of the dysleukolytemia, and within 48 hours. The prognosis will be good. But if
Even-
comes convulsion, seizure comes after 48 days, then the prognosis is bad. So can have a seizure even very early also. Though the meningitis still is not that common in 10 years, but and without any symptoms like neck pain and altered sensorium after convulsion, very unlikely baby was at that time having meningitis.
And even that also, that story of 15 days, you should go in the details. Number one, after the seizures, what happened?
Yes.
Probably there was no seizure, but was the child totally all right? May not be totally all right. Maybe remaining some sick, may not be the same energetic. Appetite may not be the same, may not be the same, I will say, activity and playfulness. So these points will give you the idea that, of course, later on the child was at least some symptoms free, but not totally well. That again gives the idea that some illness is going on. All these points parents may not complain because they don't have the importance of it. But for us, it is very important. So I think that part you should go in the details, that in between what was the situation and how was the child, right? So I think that you can go in the details of it. Okay.
Next.
The point is, history taking is not just to ask some of the questions and to get the answers. Questions should be also having some my base, that what I want to gather the information, what is my idea, and even which parents may not even understand this importance, but to me, and when you put all the information in chronology, as madam was pointing out very rightly, chronology also gives us the exact pathophysiology, pathogenesis of the disease. Fever at least indicates some inflammation, maybe infective, maybe non-infective. That gives us the idea. Now with these other symptoms, seizures, and even the altered sensorium, the anatomy CNS problem. Now with that CNS, you are thinking some inflammation, and is it infective or non-infective inflammation? That's give us the idea. And then probably at very rightly already to discuss that most commonly acutely starts, then probably acute encephalitis syndrome. But somehow that sequence is not fitting in our patient. So therefore not convincing us. Okay, in the medicine, everything may not be that sharp, but probably the common story which we are used to listen, that's not convincing to us. As madam said, probably bacterial meningitis, yes, it is common, but I think age of the patient, the story of the illness, usually how commonly bacterial meningitis starts. Fever is the first with the bacteremia. Then, localization in the brain, so CNS, and with that some CNS symptoms will develop. Young child irritability, older child maybe some sensorial changes or something, then signs of raised intracranial pressure, headache, vomiting, and then the seizures. I think these are the, and meanwhile maybe some neck pain or something, some symptoms will be there. That will give the idea that, oh, this is likely acute bacterial meningitis. So the point is, as a postgraduate, from the whatever the information is available, we have to thread it properly, and then threading and then putting it in a proper sequence and then narrating the story. I think very rightly it was pointed out that our description should be palatable, right? It should be convincing. I understand you cannot do immediately. This is our, I would say, beginning. But I think if we start from this beginning, gradually we can reach to this our goal, right? So take it, I will say, that way. You are doing very well, very well. After what we are discussing after 35, 40
Yes,
months, yes.
Yes,
And you are doing after the 30 months. So I think you are doing very well. That's the point. But the
Yes,
point is, these are some points to bring to your notice, all the postgraduates, that how we should do it. Right, very well. Please go ahead.
In past history, patient had no past history of any hospital admission for any medical or surgical indication. In birth history, patient is a singleton pregnancy was there, male child with full term of gestation, born via vaginal delivery with birth weight of 2.5 kg and baby cried immediately after birth. This was a home delivery and there is no history of NICU admission. Proceeding towards immunization, it is completed up to 5 years of age and BCG scar is present. Optional vaccination is not done and documentations are not available. In developmental history, patient is studying in 5th class and is average in studies. Developmental milestones are achieved for the age and there is no developmental delay noted. In family history, patient is a 7th born out of total 7 siblings. And contact history of TB is positive in mother and mother is Putum positive case of tuberculosis and an AKT since 2 months. There are 4 sibling deaths in family due to some illness, out of which one died with sepsis and other died due to minor illnesses, but father does not know the exact cause and not have any documentation. In socio-economic history, patient is living in Kacha house with nuclear family of total 4 family members and belonging to lower socio-economic class according to Kupuswamy scale 2021. And they are having access to municipal water supply and there can be low parental concern for the illness and medical attention for the children.
Can I interrupt you, Dr. Prachi? What sir pointed out was very, very relevant. Your history is also now bringing it out. That see, for the father, probably the event of a seizure and fever on that day was very important. And probably he might have not noticed or might not have paid attention to maybe low-grade fever happening before. With that history of tuberculosis in the mother, I think, you probably, if you dig little deeper, you would find that there is some history of some lingering fever, maybe, 10 days before that seizure happened. Okay, so what sir said is absolutely very important. You have to dig. In such cases, you have to, dig deep and ask if symptoms were present really before the child had a seizure. Because for that father, for that mother, that seizure is a very frightening event. But you know that the sequence of events is not fitting in what you've seen so far, isn't it? So as a rationality, you need to ask whether there was any pre-morbid history before the seizure really happened.
So can I comment something over in the history? Dr. Prajapati sir?
Yes, madam. Please
Okay.
go
Yes,
ahead.
ma'am.
So for, you just show the history of present illness. Yes, just next slide. Next slide. Okay. You have written no history of double vision, behavioral abnormality and all those things. First, what is your aim? This is a case of neurological disorders, most probably of infective origin. That's okay. Now you have to decide what topography, what is the topographical lesion, means which part of the body is involved. Second is what is the physiology of that, means hypertonia, upper motor or lower motor nerve. Neurology, there are rules, there are 5-6 steps to diagnose. Third is the first, then physiology. What is the physiological type? Upper motor neuron or lower motor neuron, flaccid type, tonic type, rigid type. On the history only, you have to take it out. And third, where is the site of the lesion? Fourth, what pathology on that site? And fifth is the etiology. So first, you have to, as you said, there is altered sensorium, conversion, but didn't mention about the cranial nerves. Serially, you have to mention all the cranial nerves about it. Like you said, the double vision. Then there is no third, fourth, sixth. Then you have to say about the seventh. If there is any deviation mouth or any crying, any nasal tongue, like in 10th cranial nerve. Each cranial nerve by history you have to take it out because you have to give the total full diagnosis. So you have to say after convulsion, baby is okay or can move all the limbs. As you said, loosening clothes justifies the loss of weight. Similarly, whether baby could move his limbs, upper limbs, or could walk. What is the facial?
Yes, sir. Yes, ma'am. Patient was able to move all 4 limbs and
Good.
There was no neurological deficit present at the time of admission.
Okay, good. But you have to ask about the cranial nerves again. third, fourth, sixth, you asked. Seventh, you didn't ask anything about the seventh, like deviation of mouth and all, or then whether he can chew, blow, or as 10 years, he can jolly well follow your command if it's possible, or you can ask the mother, or there is any nasal twang, are there any voice changes, hypophonia, hyphonia, or speech disorder, all those to be said, okay? Then you will see the bladder and bowel, whether baby is having bladder control or not. Bladder have three type of supply. One is somatic supply, one is sympathetic, one is a parasympathetic. Okay, so you have to know the supply of the bladder supply, of course, for examination point of view. For the history point of view, you have to take the history that whether baby is passing urine voluntarily or not. Means external sphincter is under control. Okay, or there's a overflow incontinence or dribbling, and whether baby can feel the sensation of bladder fullness. Similarly, the sensation of bowel fullness and wants to defecate. So these are somatic sensation and special senses to be ruled out by taking the history. So you have to ask the mother or parents or the child if he can communicate कि आपको पता चलता है कि आपको potty लगी है, आप potty करना चाहते हैं, आपको लग रहा है कि आप you want to micturate और अपने आप हो जा रहा है. These things to be very clear, because before for localization and type of lesion you have to know this. Clear? Okay. Next, in family history, you said for my 4 children died due to some minor illness. Don't say minor illness. Minor illness won't cause death. Huh? You told me there is some minor illness, but father could not say. So minor illness would not lead to death. There's something wrong, or some congenital or hereditary disease might be there and all. Even in socio-economic history, it should be modified Kupaswamy. You have written 2021, but you must, I think, before Kupaswamy, you add the word modified. It is a modified Kupaswamy scale. Clear? Okay. This is all from my side on the history.
Dr. Prachi, you know that sibling deaths are a very what do you say, red herring.
Yes.
You would really give it a lot of importance. And if you can see, I think one child died very early, 6th day of life. So there probably tuberculosis, you may not think so much, but in that 1-year-old child or that 10-month-old child, you would think about it, but you would also think of other conditions that could result in early deaths. Okay, in those children. So you don't restrict yourself to tuberculosis, although that is the top of your mind is tuberculosis now, because there is a maternal history of being on AKT. So you would very strongly consider that this could be a tuberculosis etiology. But because the sibling deaths have happened, therefore it puts a red flag somewhere that look for alternative explanations also. So I would take that history as very, very significant.
Yes, sir. Sir, for this, I have asked history of any infection or recurrent infection in that siblings, but father was not aware about it, and he was saying that no, there was illness, and followed by that patient was dead, infant was died.
So the detailed, I think, history must be taken as to what were the exact symptoms, what was the duration of those symptoms. Okay, when did the child die? Any investigations were done? Was the mother symptomatic, at that time, or somebody else in the family was symptomatic for tuberculosis? So lots of details need to be, digged into, because this, having 3 deaths or 4 deaths is extremely unusual.
Yes. Yes.
Tuberculosis, you would not expect that 4 siblings died of tuberculosis. That is something that you would really not, be able to explain very easily. So I think for me, it's a big red sign that something is amiss here. Okay.
Yes, Dr. Rajesh, very nice. Yeah, Dr. Rajesh very nicely pointed out. It's very important to know any heredofamilial disorders or anything else. Or sometimes I would rather say, as it's like a tuberculosis, we've already said mother is suffering from tuberculosis, whether mother was tested for HIV or not. Though I'm not, I'm a HIV director, so I'm not HIV minded, of course, but I'm telling this is the possibility, and in HIV, anything can happen. So at least you should take the history, and while investigating, you must, this is the day, now I think this is the mandatory. That is illegal also. If you're TB, you have to rule out the HIV. In case of HIV, you have to rule out the TB. So when the mother is suffering from TB, you must take the detailed history and father's occupation also. Whether there is any high risk behavior in the family and the parents, or there is transfusion of blood transfusion before the mother is having, or any other symptoms of mother, not only tuberculosis. That's very important. And maybe some hereditary familial or cardiac disorder may be causing such a death. So be very specific about the symptoms. You say what symptoms you have seen among your children. That's very important. And you can guess what type of disease. Sudden death without any illness, maybe cardiomyopathy. There are maybe other disorders which can do sudden death. But if the minor illness causing death, then it is very suggestive of again metabolic encephalopathy. Some minor illness leading to the deprivation of food or some small molecule deposition, and there may be metabolic encephalopathy leading to death. These are quite possible, but we have to rule it out.
Prachi, Dr. Kinika here. You know, when I see this particular chart, what is it that is strikingly different? Like you have one child who is 26 years old.
And
Yeah.
10-year-old, yes, ma'am.
So what is the age of the mother, father, and the occupation of the father?
Yes.
Like, you know, and your socioeconomic class is also like, is it got some angle to it? Because the deaths which have happened are less than 2 years of age. So always give it a thought that is it the first marriage? Is it the second marriage? Was the mother suffering from illness? Like as the pregnancies get better, which infection you will have a live child. Initially you have abortions, and then the abortion durations go on increasing, and then a newborn is live and born. So do you know any infection which behaves like this? Okay, we'll come to it at the end of the session. All right.
Yeah,
Okay,
nice question.
yeah.
Very nice question.
Okay,
Yeah.
so we would like to
Definitely.
have those ages of the parents. Okay.
Yeah.
Okay, carry on.
Again, Prachi, can you just stop sharing?
Yes, sir.
Okay, I think if you have the history part, let us finish the history part.
Yes, sir.
Okay, or you have stopped the sharings and let us finish it. Whatever way you wish. Okay, I think many points have been derived. Unfortunately, only 2 postgraduates are there, Chinmay and Prachi. I think there must be some others on the attendees link. But the point which I want to convey, please remember, you know, the CNS, it is said that more than 80% diagnosis should be revealed from the history. So history should be so, and you know, it is, people say the mathematics in the CNS, but I would say mathematics in all the systems. And it is more so in the CNS.
Yes, sir. I do agree.
And therefore, if you have really taken the history methodologically and if you put in a proper order, probably hardly the examiner should get the space to ask the question. So always try to put in that order. And second, always you should be, I think what Amlekar sir reminds the students frequently, ABC, you should accurate, you should brief, and it should be very clear. Third, you know, whenever you are using some words, terminology, find out the proper word, because you know proper word will convey the exact meaning what you want to convey. If it is not proper, it may create some confusion, and sometimes in the exam particular point of view I'm talking, it may waste your time. Suppose here you use the private vaccines or optional vaccines. Now these are not the points, right? Even in the government sector, which vaccines we are giving, other vaccines are also expected due to certain logistic reasons government is not able to manage. But these vaccines are also indicated, they are not optional, right? So no optional, no private. On the contrary, to make it presentation, we can say that vaccinated as per National Immunization Program, right? And then it becomes clear that rest of the vaccines, probably some of this family could not manage. Similarly, another thing, I think the point which was discussed, very, very important. The family history, so I'm not sure whether, do you know what is the age of the mother?
Sir, mother's age was around 40 years.
More, I think maybe more than that, because 26 years old girl. Before that, one child was lost. At
Yeah.
least we expect that the suppose first child she got at age of 20, then also probably she should be crossing the 50. Number one. Second, age of all siblings, we'll have to try to get the exact reasoning. Of course, every time record may not be available, confirmatory diagnosis may not be available, but you can go for what are the symptoms, whether the child was hospitalized for what reason, what your treating doctor told, there may be something like that. Suppose hospitalized, some seizures and lumbar puncture was done, I will understand that again probably CNS problem was there. And here, this background of this tuberculosis to the mother, as you said, even this sputum positive, I think I will focus mainly for the tuberculosis. We should even go for the father also, not necessarily father, even father may be also having the tuberculosis, or even the grandparents. Many times even the grandmother, if you ask in details whether the grandmother is present or grandparents and whether they are having the problem, many times probably for childhood tuberculosis, that is the source, adult is the source, and that source we'll have to try to locate. And here multiple even losses of the children may be related to that or some other disorder that you should try to. And I think here HIV status is very important. What Madam said, same thought was there in my mind, that we'll have to, with the tuberculosis status, you should know what is the HIV status of the mother and even the family. Even the deaths of the children may be related to the HIV and tuberculosis. So many points are there. So I understand that everything may not come to your mind, but I'm sure that this is a learning for all of us, that these points are very important and we should collect in our history part. Okay, I think you can complete your rest of the history and then we'll go for the examination. But again, I think just to remind you, at the end of history, we should have these certain answers in the CNS question. Always, number one, anatomy, that which part of the CNS is affected from the information, right? Second, what is the likely, I will say, pathology? Is it congenital? Is it traumatic? Is it inflammatory? Is it vascular? Is it degenerative? Is it neurometabolic? And every component is having the characteristics. And from that you can derive that what is the likely pathology. And of course you can try to give the thoughts for etiology. Etiology may not be obvious, but of course you can put the common possibility. So always try to have these efforts, I will say, goal in this way, that at the end of history, we should be able to derive the inference in this fashion, so that the whole exercise will become the fruitful, right? Okay, please go ahead.
Diet history, pre-illness diet is shown, in which patient was taking 1,560 calories against expected of 2,190, and there is deficit of 28.7%. And in protein, patient is taking 26.8 grams against expected of 39.9. So there is deficit of 32% of the protein intake. According to anthropometry, patient's weight is 18.02 against expected of 30.8, which lies on the less than third centile. Height is 129 centimeter against expected of 138, which lies between third to 10th centile. And BMI is 10.8 against expected of 16.8, which is less than third centile. Sir, should I summarize the case as per the history presenting complaint part only? Sir,
Yes, go on.
Here I am dealing with a 10-year, 7-month-old male patient with history of fever, abnormal movements, altered sensorium, and weight loss, who is belonging to lower socioeconomic class, having contact history of tuberculosis with normal birth, immunization, and developmental history, with deficit of approximately 30% in calories and protein, with undernutrition. So according to history part, there can be differential diagnosis of tuberculous meningitis or partially treated pyogenic meningitis or acute encephalitis syndrome.
Okay, now I think stop for a while. And all of you know that at the end of history, we'll have to give the summary with some your probable possibility, the very which probably we discuss. So I think Chinmay, you can try. Give the summary of history part. Prachi, can you just stop sharing for a while?
Sir, this patient had the chief complaints of fever since past 15 days. There was a single episode of time and 3 days in the negative history, it was ruled out that the patient did not have any ear complaints or vision changes. Also, family history, it was evident that there was a family history of tuberculosis, and there is history of many multiple sibling deaths. Also, on the diet history in the anthropometry, it was evident that the patient is undernourished, and both height and weight are below 100%. Also, BMI was below height was less than 10 percentile, and BMI was less than 3rd percentile, indicating that the patient is again undernourished. This was evident from this. Also, immunization and development history was taken, but they were within the normal limits.
Please remember, for the sake of the students, in the summary, there should not be the repetition of the same points which already you have discussed or narrated. You know, on the contrary, the summary should be in the form of the inference, what you have understood from this presentation, because already you have presented your story. You have given the details of the history. Probably examiner might have taken some points of discussion, right? And from the discussion, ultimately what meaning you are deriving. And that should be, I would say, very short, about 8 to 10 sentences. And I request all the students that it requires the multiple time exercise. Nobody can do spontaneously immediately. I understand. We'll have to do the multiple times attempts. And for that reason, in your daily round, at least in some of these type of patients, make the habit. Even at the beginning, you may try to write down on the paper that what you want to give the summary, and then present to your teacher. The teacher may suggest some modifications to again I will say in a better manner, and continue in this way. And if you do in this way spontaneous to the exam, your summary will be impressive. And you know, if your summary is impressive, it carries, I will say, the good impression and even the scoring also. So that is very important. I think simply if we have to do in this patient, you know, many points, just for that reason, you can write down the paper, piece of paper, what points you want to cover. You can say here it is almost 10.5 years old boy. You can say the illness of probably 15 days or beyond that. And that is in the form of the fever, so likely infection, inflammation or infection. With this probably CNS changes, you are indicating that it is, you know, it is a cortical involvement. CNS part, what part is involved? Cortical, seizures, altered sensorium, right? This indicates cortical involvement. Probably anatomically you can say no cranial nerves are involved. Probably no the point indicating the brainstem involvement. And as you say, no motor deficit. So then your anatomy becomes clear. This is just to make up the point. Then you can make the story. Later on, with the reference to this CNS infection, very strong history of tuberculosis to the mother probably becomes a very good background for you to consider likely etiology or that pathology, the tuberculosis, right? And then you can go for even some other possibilities because nobody can keep only one possibility, right? And for that reason, I think in the short, if you have to put the summary, you can say 2 and 10.5 years old boy presented with a illness of 15 days according to the parents, started with a fever and seizures and later on vomiting and altered sensorium. If I put all these symptoms together, it indicates some CNS infection, inflammation, but probably here infection is more likely. And with that, mainly anatomy indicates the cortical involvement. Pathology is likely the tuberculosis with a reference to open case of the tuberculosis of mother. And therefore, in this patient with even the background of weight loss, even emaciation, decreased appetite, probably it becomes a clear background that as tuberculosis is more likely. But with reference to some other points which remains unanswered, multiple sibling deaths and other things, I would like to go in the details with the HIV status of mother or even the tuberculosis status of other family members, which will provide me some idea that is it only tuberculosis or some other possibilities are there. And I think if you prepare your background, so you are keeping your even possibilities open also. You are not just closing with this tuberculosis. And that will have to keep even. Even somebody may ask even beyond tuberculosis what you are thinking. Suppose forget regarding the tuberculosis contact. Tuberculosis contact is not there. And this type of story. Suppose 1 month story is there. Fever, seizures, everything. The point is chronic CNS infections will have to keep in mind. Occasionally brucellosis can come. Not so common, but yes, it has been reported. Even cryptococcus meningitis can come. I think before that first possibility, always you should keep in mind that bacterial meningitis, but later on chronic or partial treated bacterial meningitis. That, any chronic CNS infection behaves just like tuberculosis. But everybody feels tuberculosis. But later on, it may turn out to be cryptococcus or brucellosis or something like that. And of course, as you said, bread abscess and other possibilities should be kept in mind. So the point is, of course, obvious you can consider, but other things always you have to mention. And it may happen so that what we are talking of tuberculosis may be alternately turn out to be something else. So that as a clinician, we have to keep our mind open, right? So I think that summary is very important. Again, I want to remind you, go for this, I would say, good exercises multiple times, and then there will be a good scope of improvement. And I'm sure that your summary will be very short and sweet, and it will be impressive, right? Sir, anything, Dr. Rajesh and Madam, or she should
So
go
I think,
for?
Ambedkar sir always says that use adjectives.
Yeah,
Your summary is adjectives.
absolutely.
So here I would say subacute, acquired, likely infectious or inflammatory disease involving the CNS, cortical involvement, without any cranial nerve involvement, focal deficits, with raised ICP, you have vomiting,
Yeah,
and without any focal deficits of bladder bowel, with a COX contact, sibling deaths, malnutrition, very likely that this is a chronic meningitis, encephalitis. So tuberculous meningitis first. Sir very rightly said, we have seen sometimes cryptococcal behaving so much like TBM that we would misdiagnose, start on AKT, go back, and then think of cryptococcus in an HIV infected child. So yes, I would very much, agree with sir. Sir has perfectly put it. One more thing is, usually tuberculous meningitis, sir always says it is a global encephalopathy with a focal deficit. And what I am not seeing here is a focal deficit. So that still, I am still saying, that tuberculous meningitis 99% yes, but keep in mind that there is no focal deficit. Maybe on examination you'll find it.
Yes.
So that's a possibility. Let us keep that in mind. There's alternative explanations as well.
I think Dr. Rajesh has put it very nicely.
Nicely summarized.
To be very frank, better than what I was trying. Let
No,
me
no,
even
sir.
express. Let me express over here. Certainly, certainly.
Yeah.
And the very point I think what he's mentioned, always use the multiple adjectives. Very, very, I will say point to be noted. Always, is it acute, subacute, chronic? Try to find out. May not be right every time, but your interpretation. And then progress and recurrent and all the things will, it automatically gives a, I would say, your expression what you are considering. You have not to speak anything. So that's very important that you use the multiple adjectives, and then in a very short few sentences, even you can convey the whole your story. Very nice. I think all the students should keep in mind. Now, Prachi, you can go for further, I think, examination.
So, sir, here the date of admission is 14th December, and I have examined patient after 4 days, and the examination is after of 4 days, where some of the neurological deficit were seen, were developed, and that are shown in my CNS examination.
No problem, no problem. I think whatever you have, you can say that these are the findings after 4 days.
Yes, sir.
Yeah.
So, sir, proceeding towards general examination, I have examined the patient in full daylight with adequate exposure and isolation after taking verbal consent of his father. Patient was lying supine in the bed, poorly nourished and thin-built. He was drowsy but arousable, not oriented to time, place, and person, with IV cannula in the left hand and SpO2 probe over the right index finger. In the vitals, temperature was 99.5 Fahrenheit in right axilla, measured with digital thermometer. Pulses were 86 per minute, which were regular in rhythm, adequate in volume in right radial artery, without any radioradial or radiofemoral delay. Respiratory rate was 24 per minute. Blood pressure was 116 by 78 mmHg, which lies on the 95th centile, taken in supine position in the right brachial artery, and SpO2 was 97% on the room air. In general examination, in head there was no obvious abnormality. Hair was sparse. Facial asymmetry was noted on the left side. Left side facial expressions were preserved. Right sided facial expressions were diminished. Build was thin build. Eyes were directed downwards, and sunset sign was present. Chest and abdomen was normal. External genitalia and extremities were apparently normal. Mild pallor was present. Rest of the examination was normal. In systemic examination, as per my presenting complaints, I would first like to examine CNS, in which higher mental function, child was drowsy but arousable with GCS of 10 by 15, E3, M4, V3. In cranial nerve examination, in second nerve, right pupil was 5 mm and was reactive to light, while left pupil was 3 mm reactive to light. Direct and indirect light reflex was present, and on fundus examination on that day, grade 1 papilloedema was present. In third, fourth, and sixth cranial nerve examination, right lateral gaze palsy was present. Actually, patient was not following commands, but in between, when vaccine waning type of sensorium was there, patient was looking at his father, and after and on that we can comment that patient could not see on the right lateral side, right temporal side. In fifth cranial nerve, corneal reflex was present. In seventh nerve, right-sided facial expressions were present, while left-sided facial paralysis was present. Eye closure was adequate, but flattening of nasolabial fold and drooling of saliva was present. Gag reflex was present. Rest of the cranial nerve examination was not able to perform due to altered sensorium.
Just a minute, in cranial nerves, come to the cranial nerves. Dr. Prajapati sir, can I comment over here?
Yes, yes, madam. Please go ahead.
Okay. For the cranial nerves, no, the first cranial nerves, okay. Second cranial nerves, what are the things to be seen?
Ma'am, in second cranial nerve, first we have to look for the
Four things: color vision, field of vision, visual acuity, color vision, field vision, and fundoscopy.
Fundoscopy.
These four things should be in the exam, the second cranial, not the direct light reflex. The light reflex needs, what are the nerves is there in the light reflex?
Third cranial nerve and
second and third.
Second and third cranial nerve.
Yes. So after the examination of third, you will say the light reflex. Clear? It should not be in the heading of second cranial. It is the only acuity of vision, field of vision, color vision, and fundoscopy. Here you cannot observe the acuity vision and field of vision because baby is drowsy. So as you said, others are okay, but that right reflex, direct and indirect, will become under the heading of after 346. In 346, we see the movement of the extraocular muscles and reflexes. Clear?
Yes, ma'am.
Okay. Go ahead.
On the motor system examination, apparent bilateral symmetry was present and there was no wasting. Arm circumference, forearm circumference, thigh and calf circumference were same on the bilateral side. Tone spasticity was present on bilateral side, which was of modified Ashworth grade 1 plus. Power exactly could not be assessed, but as per the movement of the patient was not able to move his left extremities off the ground of the bed, and right-sided extremities was moved above the bed. So there was power of more than 3/5 on the right side. In superficial reflex, bilateral extensor response was there. Babinski sign was present, and reflexes were brisk on the bilateral side. Cerebellar signs was not elicited, and in sensory system, withdrawal to pain was present. In meningeal signs, neck rigidity was present. Brudzinski sign and Kernick signs were also present. In head and spine, head size is somewhat enlarged with few prominent veins visualized over the frontal region, and Messivan sign was positive and spine was normal. Rest of systemic examination were normal.
Okay, can you stop sharing?
Yes, sir.
I think first you can take this general examination. Go focus discussion so that we can have the, and she will be also clear, there should not be confusion. So first make the points clear in the general examination. Any point is missing in general examination? Prachi, are you able to recollect? There's something you have missed?
Can you tell us something about your anthropometry and then go on to the vitals? Vitals include what? Temperature?
Pulse, blood pressure, SpO2, respiratory rate.
Yes. So then whether anything correlates with your neurological presentation in this child, and something you can talk about the anthropometry, which madam right in the beginning said, is it a disease of 15 days or longer? Actually, your anthropometry will tell it the answer very easily. Try to bring it. You have to show off in your exam, your knowledge, not keep it to yourself. So make
for that reason, Prachi, what is missing? That's my point. I think growth chart is not there, is it?
Yes, sir. I have not attached in PPT. Yes.
Yeah, and please remember, in the MD examination, never miss it. Whatever the system it is, whatever the system, because missing the growth chart, some examiners may not consider us. Because now you know that so much importance we have realized that, and I'm sure if you put over here the growth chart, that will provide not many informations regarding the particularly the status of the nutrition or everything what we are discussing, right? So that was the point which I thought that it is missing. Even BMI chart should also be put over here in the general examination. That is very important. You said child is drowsy and arousable. Try to interpret it. What does it indicate? What it suggests?
Sir, patient has excessive sleepiness, but on the somewhat external stimuli, that is vigorous pain, patient can be arousable, and on the time of arousability, patient is able to know that his father is standing beside him.
Prachi, my point is very clear, and therefore, the student should also be the sharp that what the examiner is asking the question, you should catch it. My point is, again, I remind, because I think I want to sensitize you rather than answering. You said drowsy and arousable. These two words you have used. Do you want to convey something? They are same or different? Functions point of view, CNS functions point of view. I think drowsiness, arousable. What's the difference? Come on. I'm sure that you must have some idea, but I want to
Sir,
motivate you.
are you asking for the awareness and arousability?
Whether they are same or different?
They are different, sir.
What is difference?
Sir, awareness is something.
Particularly, I would say talk in the language of components of CNS point of view. That means which component will give you the idea regarding function of the drowsiness or orientation point of view. And second, arousable, which part of the CNS is intact or involved, or you can derive it.
Reticular ascending system, sir.
Good. Very good. And I know the students are knowing. Teachers' work is only to bring it to the surface. Students are always knowing. But they don't know exactly that this should be my answer. And therefore, I think that is another thing. Gradually, I am also learning that how to teach the students. If I just answer, probably the purpose will not be served. You are reading even from the book, right? But the point is that how and the difference you will remember. You know that awareness of orientation is a cortical function, right? So yes. You are assessing indirectly the cortex. While arousability, the best point to understand, sleep, wake, sleep cycle, what we say. And when that cycle is disturbed, that cycle is under the control of ascending reticular system. And when it is affected, that's a separate component of the consciousness. And involvement of this component indicates involvement of ascending reticular system. I think best example which you can remember is hepatic encephalopathy. In hepatic encephalopathy, before anything impairment of consciousness happens, there is this cycle of the sleep-wake, sleep cycle is disturbed. And that is the best example to understand that, before anything happens, you understand that this is going wrong with this system. Here you say drowsy but arousable. So I understand that probably it's a cortical function is compromised or affected, but somehow the ascending reticular system is intact. I think that's the thing which you are conveying. So, when you are speaking, I think this should be clear in your mind. Very good, but you are knowing. You said I think Madam also made the point clear. In the Histian examination, cranial nerves, every cranial nerve is having very specific function. You narrate in such a way that it becomes clear whether it is normal or abnormal. Right? So that is also an art. You can probably write down in your note and prepare it and just refer on the previous class examination so that you remember and your performance will be good. Right? So I think that you should do. You said right side pupil is 5 millimeter, left side 3 millimeter. What is your interpretation? How do you take it? Normal or abnormal? If abnormality, where is the abnormality?
Sir, abnormality is there because of unequal pupils. There can be raised ICT which is leading to this. And the right-sided pupils are right-sided pupil is dilated, which means there can be herniation can be present due to raised ICT, or there can be there can be any space occupying lesion can be present at that place, which can lead to.
I think simply you can remember that the unequal pupil is always abnormal. Right? Unequal pupil, except barring some physiological which can be rare. But I think as a general pediatrician for us, that we should always doubt it, that this is abnormal. So that you should do. Second, you mentioned papilledema. How much time it requires to develop the papilledema? Generally, in most of the diseases, barring very few where even within the short time develop, but commonly. Try to guess if you don't know. How much time it requires to develop the papilledema with raised intracranial pressure? Pathology may be anything.
12 to 24 hours, sir.
I think it's too early. It cannot develop. Papilledema requires more time, few weeks. And therefore, that is the indirect evidence that this illness is not of 2 weeks. Probably it is more than that. Presence of papilloma indicates that probably this illness, whatever it is, of probably beyond the 2 weeks. You know, that indirect, we can gather the information. Regarding you said head size is large. Child is 10 years old. Do you expect that this that with these raised blood pressure or hydrocephalus or something, the head will be enlarging?
Sir, that is
In a 10 years old child, huh? I'm talking.
No, sir. The head size cannot be, it cannot be large, but there is a presence of prominent veins over the forehead. So head looks a bit larger than the usual.
What
Yeah,
is the head size?
I think you yeah, what is the head size? You must have measured.
Yes, sir.
She has not mentioned. She has not mentioned. I noted.
4 centimeters.
Anyway, another point, you know, you have mentioned some Mesevan sign. Prachi,
Yes, sir.
what is it? It's a interpretation, present or absent.
Sir, Mesevan sign can be present in case of hydrocephalus.
No. Here, what is your interpretation? Present or absent? It's present.
Sir.
What's present? So, what does it indicate?
Raised intracranial pressure and hydrocephalus.
Now, Mesevan sign will be present up to what age? That sign, except absolutely you are right, that indicates raised intracranial pressure. Is there any age, range, during which time this sign can be taken for our interpretation as the evidence of raised intracranial pressure? So what is that age? Suppose child is 1 year old. Can I take the 7 sign? Why?
No, sir. Sir, sutural closure is a prerequisite for the Mesevan sign.
Okay. So now suppose in the adults, 30 years old boy even, can I use this Mesevan sign will be present in the case of hydrocephalus? In another way, at what age then the osseous closure of the sutures? You know why the Mesevan sign is present in older children? Because already anterior frontal is closed. But even sutures are closed, but they are membranous. They are not still the osseous closure. And therefore, with the increased pressure, they can even reopen to some extent. And reopening of the sutures gives presence of the Mesevan sign. Right. So that can also be up to what age? Up to 18 years. So Mesevan sign is important from 2 to 18 years. 2 years because before that EF is open, so I cannot use. After 18 years, it is totally closed. So with raised signs, other manifestations will develop, but not the Mesevan sign. Right. So I think somebody is asking you, you should know all these points. I think before we go for further, the Madam or Rajesh can take it, please.
Yeah. So I would just like, to comment, if you remember, it is a cracked pot.
Yeah.
Okay.
Cracked pot sign.
So before 2 years, the pot is already having a crack. And after 18 years, it is so strong that it cannot crack. If you remember like this, it is easy. And good thing is you got focality, isn't it? You had left-sided weakness, you have cranial nerve involvement.
Yes.
So yeah, so on history you did not get, but on examination you confirmed that it looks like.
I think
On
now,
the day of admission, there was no neurological deficit, so I taken the examination when it was present.
That's fine.
That
Anyway.
indicates at the time of there is no neurological sign, or after the 4 days neurological
days.
sign. So it is a progressive in nature.
Yes, yes, ma'am. Progressive in nature.
So that is another adjective you will add to Dr. Rajesh's adjective.
Yeah,
Okay. Chronic, progressive, like that. It's it's
yeah,
like
absolutely. I think even if you remember this much how to put it, then also it definitely becomes a good presentation at the end. I think now, Prachi, you can summarize the positive findings of CNS examination.
Sir, and the positive. So should I show the case summary or should I?
No, I think without case summary.
Yes. Sir, according to the history and
Because I want to give some exercise to you.
yes, sir. Sir, patient is having insidious onset of illness, which is chronic and progressive, with the lesion can be at the level of the lesion at the level of
Prachi, I think before we go for that summary, try to summarize only positive findings of CNS examination. That will give us the idea that where's the problem, what type of problem, and then from that we'll decide the anatomy, and then we'll go for further development of the case.
Yes, sir. Sir, with the 6th and 7th cranial nerve palsy on the right side.
Prachi, sorry to interrupt you.
Sorry, sir.
I think I should not interrupt the student frequently. It is also not good for any teacher, but sometimes we'll have to take the liberty because the story will go otherwise further. Always when somebody suppose tells the summary or positive findings, we may not speak as the undergraduate students that the higher function, cranial nerve, motor system like that. But I would say narration should come in that sequence, right? Suppose in the respiratory system, somebody said, then start from the inspection, palpation, percussion, auscultation, right? So the order should be like that. So here, I think we can start in this way, the positive finding that what is regarding the level of the consciousness, right? Then you can go for further the cranial nerves. Then the motor system 5 component, that what is the tone, power, nutrition, coordination, involuntary movement. Then sensory system, right? Then cerebellar signs. Then signs of mental irritation with the neck stiffness, Cornelis Burkitt's sign. Any cerebellar signs, right? Skull and spine and gait. I think that should come in that order, right? With that you can, and then whatever the positive findings you can put in. Now fill up the gaps.
So, sir, patient, here I am dealing with a drowsy but arousable patient, right, with who is having a right lateral gaze palsy with right-sided facial hemiparesis in the lower part of the face with response to the pain stimuli only. But patient
simply say 6th and 7th of involvement. Am I right?
Yes, sir.
Or any cranial nerve is there?
No, sir.
So you can say 6th and 7th. Then it ends there. Then go for motor.
Yes, sir. With hypertonia in all 4 limbs in form of spasticity with modified Ashworth grade 1.
Very good.
With brisk reflexes. And
I think the differentiation there, you can make it difference. That this generalized involvement of the 4 limbs, more on the, I think, left side.
Left side, more than right side.
You can say more on the left side. That's all. No gradings, degradings already you discussed. That more on the left side. Right. Okay. You can say with the upper motor neuron type of lesion, therefore spasticity, even the DTR brace, plantar extensor. So automatically it goes to that, yes, this is upper motor neuron type of the weakness is there, right? Okay. And signs of meningeal irritation present. That's all. Gait you could not assess in this child. Skull and spine. Skull you can describe in details, and then spine is normal, right? I think with these findings now, try to localize that anatomy first. Which part of the CNS is affected, or multiple, whatever you have the findings.
Sir, as there is altered sensorium, cortical involvement is present. And sir, there is there is a weakness in limbs also. So left-sided hemiparesis is evident. So right-sided cortical lesion can be there. And also there
I
is.
think Prachi tried to localize. Once what you said is absolutely right. Generalized diffuse cortical lesion. You know, it should be generalized. It should be diffuse cortical lesion. Now the hemiparesis, how will you explain? Where is the site of lesion?
Sir, can be above the level of the pons.
And suppose you know the
In
any hemiparesis or hemiplasia, that means you know these fibers should be very compact. And where is the compact fibers?
In internal capsule, sir.
Internal capsule. And then suppose the internal capsule involve, what type of pathology is common?
Dense hemiplegia is
Vascular, right? Vascular.
common.
And suppose if it is tuberculosis etiology, what type of the vascular involvement? Is it thrombosis, embolism, hemorrhage? No, it is vasculitis. More likely vasculitis, right? So I think this is the way that how you can put it. That generalized diffuse cortical lesion with 6 and 6/7 of involvement, how will you explain?
Sir, as a right lateral gaze palsy, the same side of the sixth cranial nerve will be supplied.
Prachi, can you link it with this internal capsule lesion?
No, sir.
Oh, okay, I think we'll take the help of experts. Later on, you can go further. So now I think most of the points you have explained. So what is your anatomy? Gradually, you made the anatomy clear. It's a generalized diffuse cortical lesion with likely given the vasculitis, and then which vessel is going to be involved into the cerebral artery, which has caused this with the intercapsular involvement presented in the form of the hemiparesis with even this seventh of palsy, it can be linked up with this hemiparesis. And seventh is also nearby. So probably that inflammatory or diffuse lesion may be over that part. We can presume, okay, MRI or some other things will provide the details, but clinically probably we are not that wrong, right? So I think that, is there any spinal involvement?
No, sir.
Yeah, so you can say no spinal, because in tuberculosis also it can occur. And which are only cortical diffuse, you can even the meningitis. That means meningeal inflammation is also there, because neck stiffness, kernis and Bruskins. Now you have the, meningoencephalitis, because with the brain is inflamed, but meninges are also inflamed. So now you can use even the proper word also. It's a meningoencephalitis with even the right side hemiparesis. Likely the site of lesion is internal capsule, maybe the vascular in the form of the vasculitis, and likely the pathology is tuberculosis. And tuberculosis is known to cause all these problems or this type of presentation, right? With even the, as you said, Messevines, probably hydrocephalus, that also you can put it, right? With the race signs, that can also put it. So whatever the evidences you have on examination, now you can try to explain that what pathology has caused these manifestations. And that you can put on the paper and then explain that which disease can behave in this way, whether indeed tuberculosis or something like that. So I think that is the whole story, just to sensitize you. Always keep, this case is the illustration. What is our idea? We want to sensitize you that how we can have the different thoughts or methodology of the clinical, I will say, analysis, and then to interpret it and put in a proper format to derive the diagnosis. This exercise is just sensitizing. I think now I request the expert to take it further, sir. Please, Dr. Rajesh or Madam.
Okay. Dr. Rajesh, please.
You can go ahead.
No. Okay. Actually, I wanted to ask the Prachi, is it hemiparesis or quadriparesis?
Yeah.
Quadriparesis, ma'am. Actually, we
yeah,
cannot
that's-
comment on the right-sided weakness
yes,
as well. But
that's a
it,
varied presentation. The degree is different, but it's a quadriparesis, not hemiparesis first. So this is the case, and upper limbs are okay.
no, ma'am. Upper limbs are also
Upper
involved.
limbs are so it is a quadriparesis with the cranial nerve involvement, seventh nerve, cranial nerve, upper motor neuron type or lower motor neuron, facial palsy.
Upper motor neuron type, ma'am.
Oh, so that means it is the level above the level of
Pons.
yes. So it's clear with the meningoencephalitis because meningitis sign is there and altered sensorium is there.
Yes, ma'am.
So this is a dictum we say when there is a infective origin and you cannot localize the exact pathology, think of tuberculosis. And now they oppose HIV also. And in case of non-infective pathology or immune disorder, think of multiple sclerosis.
Yeah.
So all the clinical features cannot be explained by one disease, think of multiple sclerosis. If it is not infective origin, if it is infective origin, think of tuberculosis. Clear? Okay.
Yes,
I think Dr. Rajesh, just you say.
Yeah. So I think sir and madam has brought out all the points, I would say. And, if Dr. Prachi, if you do an MRI, sir has already done a clinical MRI for you. He's told you what is the pathology, what is the
Dr. Rajesh,
complication.
Dr. Rajesh, sorry to interrupt you. Probably we are trained because in the past we didn't have the option.
Yes,
Because we didn't have the
Yes.
MRI. So probably that MRI is trained by our teachers, that how you can do it. So probably automatically we have learned it.
Yes, absolutely. So what I usually tell my students is before you send the child for MRI, I want you to write the report.
Yes.
And then tally with the MRI, what structures are involved, what did you think, and what has come positive and what is not there. So you should be surprised if something that you thought is not there, you should be surprised. Don't believe the radiologist. You can do everything you will know. Clinically only you will know. So sir has very beautifully, sir has brought out everything. You saw the vasculitis, you saw the white matter involvement, you saw the cortical involvement, you saw the hydrocephalus yourself, isn't it? The basal exudates, they're causing cranial nerve palsy. So everything is very, very well explained based on clinical grounds. And MRI is done just to say that it is so. That's all. Okay, maybe a neurosurgical management or whatever. Okay. So you don't really need an MRI to say that this is tuberculous meningitis.
I think Dr. Rajesh, let me mention here one of the, I would say, points regarding one of our teachers. Even I would like to mention the name. Dr. G.R. Sethi in Delhi. Basically, sir is interested in pulmonology. I think long back when Dr. Rohit Agarwal was president, we prepared one module for the postgrad. That was a TIPS program was given. We were some 25, 30 teachers preparing it, the module. And we were thinking that who can prepare this. And then CNS was one of the topics. So somebody suggested Dr. G.R. Sethi's name. I said, sir is interested in pulmonology. So Dr. Piyush Gupta was there. Dr. Piyush Gupta said that Dr. Prajapati, what in our Delhi medical colleges we are discussing some CNS case where we are not able to answer or think, then commonly what we do, that let us go for the CT scan or MRI. During that time, somebody said lightly that before you go for the CT scan, go for the CT scan.
Correct.
That means take the opinion of Dr. Sethi. So rather than CT scan, and before you get the CT scan, Dr. Sethi will explain everything. And sir, later on I know that so nicely you were discussing CNS. I think to be very frank, even I would like to say that certain points I learned from him. So very absolutely, and all of us are learning from Ambedkar sir also, that before, on the contrary, after this clinical work, you should go for the radio imaging. Definitely radio imaging and all this advanced technology has helped us a lot. But you should not be so blind that you should go at the cost of clinical. Then there will be deterioration. There will not be the, I would say, bright the clinical knowledge. So the point is, Prachi, even with the advanced technology, in your probably time, so many advancements will be there. But still, first basics of clinical, then take the help of advanced technology. It will add, it will help us. But if you go at the cost of the clinical, then it will misguide you. It will not give you the diagnosis. So I think this is also important message,
Absolutely.
probably which has come out with this discussion, which are probably for not only for Prachi and other students, for all of us. Thank you very much. Prachi, now I think you can go further because we have to keep in mind the timing also.
Yeah,
Yes, sir.
we have 10 more minutes to go to make it 8 o'clock, but we can exceed a little bit.
No,
more than
yes,
that.
madam. Thank you very much.
Yeah, just one thing you mentioned about papilledema. Is it bilateral or unilateral, Prachi?
Bilateral,
I think
ma'am.
bilateral she mentioned. Yes,
All
yes.
right. Okay, go ahead.
A 10-year, 7-month-old male patient with insidious onset of illness, which is progressive in nature, with left-sided hemiparesis, with involvement of right-sided 6th and 7th cranial nerve involvement, with the likely infective etiology. So, most likely dealing with tubercular meningoencephalitis, with quadriparesis, which is more on the left than the right, with right-sided 6th and 7th cranial nerve palsy, with hydrocephalus with undernutrition. Sir, I have attached lab reports of the CSF here.
Yes, yes. I think whatever you have, you can just
No.
present.
With the features of raised ICT, did you mention in
No,
diagnosis?
ma'am, this was done on the day of the admission, where we have done pudendal examination, but at that time there was no papilloedema.
Okay, okay.
So glucose was 26 and the check RBS was 124 at that time. Protein was 412 milligram per deciliter and chloride 95 milli equivalent per liter. Gram and AFB stain was negative and the total count was 41 out of which 65% were polymorph and 35% were mononuclear cells. This is radio imaging of the same patients, suggestive the tuberculoma lesion, basal exudates and grossly dilated ventricles. T2 images of the same. This is the impression of the CT scan of that patient, which suggestive of multiple granuloma with central caseation, most likely tuberculoma with perilesional vasogenic edema, and Evans ratio of 41. Sir, should I mention the hospital course of that patient?
Yeah. I think whatever you have, you can take it. You can take it.
Yes. On the day of admission, IV access was secured and blood investigations were done. Patient was started with injection ceftriaxone and injection vancomycin. Montoux test and checks X-ray were done on the same day and CSF examination was done. On day 2, Sibinet gastric aspirate was sent. Antibiotics were continued. On day 3, as signs of raised ICT were present, injection 3% NS was given. Serial sodium monitoring was done and MRI brain was done, showed grossly dilated ventricles and communicating hydrocephalus. Basal exudates, multiple tuberculomas, and patient was started on steroid, AKT, and anticonvulsant. On day 4, as features of raised ICT persisted, mannitol was also started and vital monitoring was continued. On day 5, patient neurologically worsened. A sudden episode of desaturation up to 50% of the on the room air and GCS of 8/15 were noted. BP was above the 99 centile. Patient was intubated and shifted to ICU for further management. And on the next day, patient was taken for the ventricular peritoneal shunting procedures. And on that day, at the night time, RT feeds were started. Neurologically, patient had no improvement for 3 to 4 days then after, and decorticate posturing was also developed. After day 10, physiotherapy was continued, GCS was gradually improving, and patient was extubated and shifted back to ward, and AKT was continued. On day 12, oral feed started and gradually increased. Limb physiotherapy and nutritional rehabilitation continued. On day 14, injectable antibiotics were stopped. And on day 20, patient was discharged as neurological improvement was present. Patient was vitally stable, taking orally well, given up after giving appropriate dietary, physiotherapy, and drug compliance advice.
Okay, come to the CSF examination.
Anything?
Yes, ma'am.
By CSF, what is your interpretation?
Sorry, ma'am?
Interpretation of CSF.
Yes. Ma'am, in the CSF, the blood CSF glucose level is less than 2.
Means what is the impression by seeing the CSF?
How do you interpret
Ma'am,
it?
it can be picture of a pyogenic meningitis also, and it can be picture of tuberculous meningitis also in early phase. Here, polymorphonuclear cells are predominant than the mononuclear cells or lymphocytes.
So generally, how many cells will you see in a bacterial meningitis or a pyogenic meningitis?
Sir, more than 5,200 cells are
Thousands.
seen.
Yeah.
Yes.
Thousands you will see in pyogenic, and usually tubercular will be a few hundred.
Hundreds.
Yes.
Okay. And as you rightly said, initial polymorphonuclear response sometimes fools people. We used to get a lot of cases like this.
Yes.
Yeah. Initial polymorphonuclear is known in tuberculous meningitis. So don't be totally surprised that how come there are some polymorphs here. Okay, it's very common. Did you do a gene expert on the CSF sample?
Yeah.
Yes, sir. CBNet was done, but it was negative.
Negative.
CSF CBNet was done and gastric aspirate CBNet both were done, but that was negative.
So how will you differentiate with the that is it could be a partially treated pyogenic meningitis, isn't it?
Yes, ma'am.
Okay. So what will be the difference with the partially treated pyogenic meningitis and pyogenic meningitis? Because still the glucose is low, protein is high, the cell is high, and polymorph. What else you will get to confirm? How will you confirm if it's a partially treated pyogenic meningitis?
Ma'am, clinically, first of all, the age group of the pyogenic meningitis and tuberculous meningitis is different. So patient is 10 years old. After that, on the clinical basis,
What is the age group of tuberculous meningitis?
ma'am, it can present after 2 to 5 years of age. It can present.
Yeah,
Less
okay,
likely before 2 years of age.
No, it can be 6 months to 18 months.
Very
Same
young children. In
yes,
fact, if you
both
get an older
bimodal,
child, would think of HIV.
Yes,
You really
bimodal.
strongly think of HIV.
Even in adolescent phase, it's common because there is a sudden spurt and there is a sudden drop of immunity in adolescent phase, and in young age you can get TBM. And in case of partially treated bacterial meningitis, only the culture will be negative. You won't get anything in the smear and culture that will be negative if partially treated, and even up to 1 or 2 days of antibiotic. But the other picture will be same. And in this case, you have to diagnose by PCR technique. You cannot diagnose by culture technique. That is the thing in partially treated. Of course, it is by other corroborative features and all. It is a tubercular picture. So did you kept it for the cobweb?
Yes,
very-
ma'am. No cobweb formation was there. Pellicle or cobweb formation was not present.
So what is cobweb? And how long you have to keep the CSF for that?
Sir, ma'am, due to increased proteins, there will be cobweb appearance seen
If
on
it
the
is-
face.
If it is due to increased protein, then all demyelinating patients can have a cobweb, no? There is a high increase of protein and all, many demyelinating disorders. So something else is still, not only the protein. What else? What is the significance of cobweb? If cobweb is present, then what will you say? Huh? What is the interpretation? If you get the cobweb, then it is says.
Tubercular meningitis can be there.
What? So if it's only protein, then why did you say it's a tubercular meningitis? Why not demyelinating? Yeah. So there is a point. No? Actually, the cobweb is because of the AB bacilli entangled with the fibrin strands and the proteins and the cellular elements to make the net, that is cobweb net. So if you get the cobweb, if you've ever been lucky to have a cobweb, you go it for the AB and you'll get the AB bacilli by microscopy and culture. That is diagnostic. But as you know, the CSF AB is very rare. We don't keep it for all because cobweb is very rare. You don't get in all the cases, 3 to 4%. I think, Dr. Prajapati sir, am I right? Is it 3 to 4%?
Yes, madam, absolutely. Madam, absolutely.
Yes.
Very valid
So if
point.
you keep the 100 samples, then only get the chances of 3 to
Yeah.
4%.
Because
And
we have learned the cobweb only the past because all this
Yeah.
facility was not available.
Yes, sir. And it should be kept it at least for minimum for 6 hours. But what we used to
Yeah.
do, we used to keep it 24 hours. Today we keep the CSF cobweb and next day morning we'll see. So, but at least 6 hours you should keep this. And very simple it is. But I think nowadays though no residents used to keep the CSF for cobweb. Okay. Next we go and others. Okay. MRI. What else? What else you could have done with the MRI? As you said, there is you did the shunt, no?
Yes.
Patient is on shunt, still on shunt.
No, ma'am, MRI was done first. After that, patient was sent for the VP procedure, VP shunting
Okay.
procedure.
Okay.
What is the differential over here? Is which part of the brain the so-called tuberculoma is? Which part is that?
I think
Cerebral.
any other slides are there? Only this slide?
No, ma'am, slides are.
Okay.
The
No, MRI slides?
MRI slide, if you can show. See,
Two MRI slides.
why is it not a brain abscess? Partially treated. You see, you go back to your history. This child had gone to a private hospital and then treated as dengue. Did you take a history where the child was also put on antibiotics that time?
Yes, ma'am, child was kept on antibiotics.
Must be on antibiotics.
Yeah, because if you do your differential, that site which is there, is it a partially treated and a developing abscess which is pyogenic, which is not yet ruptured? Because he deteriorated after going home, like probably the antibiotics were stopped within 5 days, isn't it?
Yes, ma'am.
And then he deteriorated and came back to you. So is it possible that these are all brain abscesses and not tuberculomas? What is the difference like that?
Ma'am, as per the MRI in tuberculomas, we can see these ring enhancing lesions with the hypointense center. While in brain abscess, there will be the double ring appearance in which there will be the outer capsule with inner fibrocollagenous tissue and followed by the hyperintense core with the abscess.
So we can see that in the right side, no? Right? It's quite smooth. The left side one, first one is showing little irregularity. The DD remains the same, no?
One more
what
thing,
is it?
in this case, sorry, ma'am.
Go ahead, Rajesh.
Yeah, so what, many a times what happens is a patient goes to a hospital, they give IV antibiotic and steroids. And if you give steroids to a child with tuberculous meningitis, the child will get little better. If somebody gives, say, amikacin or drugs like that, which are again second line also. So sometimes there is a transient improvement in TBM, and then when you withdraw the steroids, then the child will deteriorate again. This is a very common occurrence that giving steroids will change the natural course of the disease. So I think that also we should keep in mind.
Okay, so if you show the CT, then those ring enhancing shadows are also there in a partially treated pyogenic meningitis, which is there, which happens in your older children where the complication is of a brain abscess. So there are not many indicators of investigations which are like TB meningitis, isn't it? Except the CSF where you said it could be partially treated. So what is the chest X-ray of this patient?
Yeah.
Chest. And
Yes,
the mother's X-ray also.
Yes, sir. Chest X-ray was done, but it was not suggestive of any fibrotary cavity or anything. Fibrocavitary lesion was not present, or miliary tuberculosis was not there.
What about Mantoux was given or it's not given?
Negative, ma'am. Montux was given on the day 1 only, but it was also negative.
HIV is
So why do you think it was negative?
HIV was done.
Why was Mantoux negative?
Why was Mantoux
Generally,
negative? Dr. Rajesh is asking.
Sir, Montux is not diagnostic for the any tubercular disease. It is like there can be exposure, and Montux can also be positive in that patients also. So it can be negative.
This child is malnourished also. Remember, this child is very malnourished also. Okay,
I think here the point what Dr. Rajesh wants, that suppose if it is tuberculosis, even here you have not got it, but suppose macrobiological confirmed diagnosis is there, but still Mantoux test is negative. That how will you explain? I think that's very, because already you described that the child is having that. Prachi, you must have brought some photograph of the patient, because now the class discussion, we have the patient, so we can see the patient. I think here in this type of the platform, we don't have these patient. Therefore, I think you can bring some evidences or some signs to show some photographs of the patient. So that will probably give the good visual impression to all others, those who are attending. So I think that is also good, which you can keep in mind. But suppose somebody asks then even in which conditions Mantoux test can be negative in spite of even tuberculosis. Somebody asked even in their Viva also. So one is
Sir,
the severe acute malnutrition.
immunodeficiency.
Yeah, any
HIV.
immunocompromised status, HIV status, right? This even can be. And before that, many a times, even PPD is not preserved properly. You know, PPD should be kept at 2 to 8 degrees centigrade, but many a times if you see, it is on the table of the OPD only. And that's why many a times it was even negative. So starting from the technique and preservation and so many things,
And
which you should keep in mind.
even it's a overwhelming infection like miliary
Yeah.
even TBM
Yes,
also.
yes, yes,
And
yes.
in incubation period, if it's an incubation period, then also it will be negative.
Absolutely. If no point, I think, can you just, Prachi, stop sharing?
Yes, sir.
Prachi, why this ceftriaxone and vancomycin was started on admission? What was your idea?
Sir, firstly, considering it as a partially treated pyogenic meningitis, actually, when the first patient came, we have the differential diagnosis of pyogenic meningitis.
I think Prachi, on admission, when the child is brought, you have the clinical findings suggesting some meningitis, right? All the points will take some time, lumbar puncture, everything, right? So immediately somebody must have started ceftriaxone and vancomycin, probably before any hand of any investigations. Am I right?
Yes, sir.
And the point is here that what was the idea or what we should do? Is it the right step or is it not appropriate? What is your comment?
Sir, we cannot wait for the time if it is a pyogenic infection and it can flare also. So at that time, we can give antibiotics before the culture reports or CSF reports.
Okay, I think here you know what the examiner wants to know. Any suspected case of meningitis, that bacterial meningitis remains one of the possibilities always. Because clinically you can't say even encephalitis syndrome also. And therefore, the first always the ceftriaxone has to be started. The reason is, you know, it is said that even if you wait for some time, that few hours even will cause the damage to the brain. Child will survive, but with even some sequelae. So I think, and they say that even waiting for a few hours is also not permissible. And that's why I asked some of the students, you know, there are certain medical dire emergencies where you are waiting for a few hours can cause the damage to the child. And therefore, suspected falciparum malaria in the endemic area. Similarly, vitamin D deficiency in a case of measles. Even, you know, tomorrow the child will be having the blindness. It is possible with severe acute malnutrition. It's a great. Suspected hypothyroidism, work immediately. Suspected CNS infection, particularly bacterial meningitis, ceftriaxone immediately. The people say that suppose if you give even the on the spot where you are standing, too much some of the people insist. So I think antibiotic justified. But the next question, why the vancomycin? Ceftriaxone okay. What is the justification for the vancomycin?
Sir, can we Staphylococcus aureus can be the organism and less common.
In a 10 years old child?
Less
You
common.
wouldn't get, isn't it? Yeah. You wouldn't think of
Prachi, then the question will come in this way. What are the most common organisms as different age group? And you know, starting from neonatal period to infancy, to even the toddler to above 5. And you know, above 5, most common organism is streptococcal, world over. Now the streptococcal, if you target, suppose now I am coming to the point clearly. It is targeted organism is streptococcal. With streptococcal, how the vancomycin is justified.
Yes, sir.
So now the question is more clear probably to you. I'm asking this question because you are answering very nicely, and you are to be very bold to answer the questions and to face the multiple people more than 2.5 hours for the second or third year resident. I think it requires definitely patting your back. I will really appreciate. Sometimes even being our teachers will not be ready to face on the dais for more than 1 hour, because from the audience so many questions will come, but you are without any hesitation answering. I think to make your point clear, initially few years back in our infection disease chapter we are discussing Nielsen. If you read Nielsen, is mentioning in the previous edition also vancomycin, because they are facing this streptococcal, penicillin resistant streptococcal. But we said in our country, India, somehow, fortunately, it was only 8%, 8 to 10%, not significant. And therefore, we were not ready to accept the Nielsen from this point of view. So we were not following vancomycin. Even in previous edition, it was the 20th edition. This is 21st edition, Nielsen is going on. But later on, which report of our country changed our mind? And I remember that lots of the discussion, Dr. Tanu Singhal, Vijay, Suhas, and Sham Kukreja and myself, we had also that. Somebody asked that, what you will do for your grandchild? Unfortunately, it should not develop, but by chance. And the answer, in the Vellore, the study was there from the multiple centers of our country. And they got probably some 37 to 40% resistant to this penicillin. And then they said that this is a great damage to the brain. By chance, even if it is less than that, which we cannot afford. For some other infection, probably you can have the time to change the antibiotics. Here we don't have the time. And therefore now it is accepted in our country also that for streptococcal CNS infection I'm talking, not for respiratory and other infections. For CNS infection, we should go for the subtrigeminal vancomycin up front immediately once you start. So I think that was the explanation which you should go. I think with the reference to miliary, here the chest X-rays, Madam asked Dr. Aarti, very appropriate question. Chest X-ray is very important. Probably you should check many things. Is there any lymph node, paratracheal, subcarinal, anywhere even, or miliary shadows? And on the contrary, in the X-ray, if you have the doubt for the miliary shadow, this is the indication for the CT scan. Usually we don't recommend the CT scan, CT thorax I'm talking, in the children as far as possible avoid. But suppose if you are suspecting miliary, and if you don't have the clarity on the chest X-ray, we should go. On the contrary, another point, if you have got the miliary in some child, younger children, it is common, as Madam was discussing absolutely. Even in the absence of CNS signs, go for lumbar puncture. Even in the absence of CNS signs, because miliary and CNS tuberculosis, I don't remember the exact percentage, but the good percentage is there. And not to miss it. And on the contrary, commonly the children are malnourished. So in the presence of malnutrition, you may not get the signs of meningeal irritation. That's why even with miliary, always to do the lumbar puncture is also very important, which you should do. You mentioned some decorticate rigidity. What do you mean by the decorticate?
Sir, in decorticate posturing, bilateral upper limb goes in the flexion posture with the extension of the lower limb.
And what is the decerebrate?
Sir, all 4 limbs extension is there in the cerebrate.
Okay, where the prognosis is good. Either of these two. That's why I think as a clinician we are discussing.
In decorticate posturing, sir.
Okay, I think you are guessing, but answer is right. Good. I think, the decerebrate, decorticate, suppose it is there in the exam, they will ask. Even then they will ask, how will you differentiate dystonia? Because these are the confusing, and I think as a clinician we should be clear. Just to remind you these questions I asked. How much CSF you send for the gene expert? Amount of CSF is also very important.
2 to 3 ml,
Yeah, that's why I asked the question.
10 ml gel.
It is, they require the 5 ml of the CSF or the gene expert. And how much you are expecting, suppose if it is tuberculosis, can you say the sequence in which specimen gene expert likely more positive in a case of tuberculosis and less chances and then least chances and no chance? Please remember the solid tissues, lymph node biopsy or any tissue biopsy. I don't remember the percentage, but more chances, probably 60-70% chances of positive in a case of tuberculosis. Then the CSF and even this gastric aspirate, gastric lavage, sputum, less chances in pleural fluid and ascitic fluid, and not in blood, urine, and stool. So I think because this is advanced good technology for us, people may concentrate for you for the examination. I think here we'll have to keep in mind regarding the time also. Otherwise, the chapter like tuberculosis there in the end. The only one thing which I would like to remind you when you have brought the good case, I remember in 1983, Dr. P.M. Udani, Dr. Vrajesh Udani's father, he reported one case in Indian pediatrics, 1983 I'm talking. CNS tuberculosis in one only patient with some 13 CNS lesions. That there was the hydrocephalus, there were tuberculosis and arthritis, there was even the exudate, even these tuberculomas, even this pituitary involvement. So many things is described, and that type of the cases were seen during that time. And therefore, very, very rightly what Dr. Rajesh was telling, multiple global involvement with the focal. I think that was very strongly taught to us because we didn't have the CT MRI. Blindly consider it is tuberculosis. And I think even in this modern time, still we are right. So I think these are the points which as a clinician we can remember. I'm sure that you must have sent for the culture, CSF.
Yes, sir.
Which method? Which method we follow at present? Any idea? You must have heard the MGIT. I'm telling you all this. I'm telling you all these short notes for examination, right?
Yes.
At MGIT, Gene Expert, these various presentations, right? And one point which you have not touched, but please remember the paradoxical phenomena. Suppose this patient you started the drugs improving and then deteriorates. I think that is also not uncommon, which we should keep in mind. And many points are there, but we have done should we end? Because we'll have to see because this Dr. Aarti is in charge today, so we'll have to look at the madam.
Regarding the timing. 15. I think so for TB CNS case, there is no end because that decides your future in the exam.
We'll end over here.
Okay.
Dr. Prachi, but first again, I would like to appreciate you. You select the very good case. Your case is good. And you tried to present, I will say, really in a very good method. I will say, preparation was good, highly appreciable, and even your mentor must have done the good job. And I'm sure that even both the experts, Dr. Rajesh and Dr. Madam, Dr. Kalpana Datta, added so many points for our learning. And of course, I know that Dr. Aarti have always remained silent, but in between her, I will say, points are always so varied. And I'm sure it is going to be quite useful to all of us. As I'm always telling, mutually all of us are learning, not only the students. And certainly I think that was a good exercise for all of us. Thank you very much for giving this opportunity. I think I should even appreciate Dr. Yogesh and his team for giving us this opportunity. And of course, all the office bearers. Thank you very much, madam. Now over to you, please.
Is Dr. Yogesh, sir, are you there? Otherwise, we will end it over here. So on behalf of eGurukul, yes, sir is here. So would you like to make some comments, sir?
So thank you very much for the nice conduction of this eGurukul program today. And as always, wonderful discussion. And Dr. Prachivani presented very well. And you have conducted very well. Thank you very much, madam. Let us meet on next Saturday. Next Saturday we are busy. Mostly we will be Dr. Nehal and me. So if you want to continue, then continue, please.
Will depend on the students. If students
Yeah.
are ready, otherwise then we will have a gap of one Saturday and
Yeah.
then come back on the following Saturday. So
Yeah.
for e-Gurukul, I would like to thank Dr. Kalpana Datta ma'am, Dr. Rajesh, Dr. Prajapati sir. I shouldn't be thanking him because without him we can't have the program.
No, no.
And Dr. Prachi, you have done really well.
Yeah.
So you passed the
Thank you,
exam
ma'am.
today, okay? But there are things which you can go back and maybe improve on your this thing with all these inputs which were given. So I'll thank everybody. I'll also thank Debelina for being there and conducting it and giving us a platform. So thank you, Dr. Yogesh sir.
Thank you.
You can wind up and close
Thank
it.
Good
So the
night.
session
Yeah,
is
thank
you
you,
very
Dr.
much.
Thank
you.
Aarti, and
Thank you,
thank you.
Good
Prajapati
night.
sir.
Good night.
And
Good
it's,
night.
yes,
Thank
and it's
you.
always love to hear from Baldev sir. It's such a
Thank you, madam.
It's a pleasure.
yeah,
being there, sir.
really
Thank you
pleasure
very
to have with us a discussion. And all the best for Prachi for your future exam.
Thank you, ma'am.
Yeah.
Yeah,
You did very well.
yeah.
Yes, very well. Very well.
Thank you.
Thank you and good night. Good night.
you.
Yes,
friends.
Thank you.
Bye.
thank
you,
you,
ma'am.
Thank you,
everyone.
sir. Thank you, ma'am.
Good night.
Thank you.